Welcome to the Deep Dive, where our mission is to take the densest, most intimidating sources, the textbook chapters everyone dreads, and really carve out the essential knowledge you need to anchor complex subjects.
And today, we are definitely wrestling with a big one.
We really are. We're tackling a true monster of the medical school curriculum, clinical biochemistry and metabolic medicine. Specifically, we're embarking on a deep, customized dive into Davidson's Chapter 19.
It's a chapter that's, it's notoriously critical for first and second year medical students.
Absolutely. It's the nexus, where the management of fluids, electrolytes, lipids, and all those rare but essential inherited metabolic disorders come crashing together.
So our goal today is to give you some really robust mental anchors for this massive amount of material.
We want to hone in on the concepts of homeostasis, differential diagnosis, and the fundamental management strategies that you'll actually use.
And that focus is just so necessary because while this stuff can feel very academic, its clinical relevance is it's unmatched.
You were telling me about some of the numbers behind this.
Yeah, consider the sheer volume. Estimates suggest that something like 60 to 70% of all critical decisions made daily in acute care hospitals.
60 to 70%.
That's right. And over 90% of the diagnostic data is stored in electronic medical records. It all relies on laboratory services and how you interpret those biochemical results.
Wow.
So, mastering this chapter means understanding the underlying pathophysiology for the most common and the most dangerous presentations you will ever see on the wards.
Like the patient who's volume depleted.
Exactly. Or the acute hyperkalemia that could stop a heart, or that undiagnosed metabolic acidosis that needs immediate life-saving intervention.
When you put it like that, that 60 to 70% of critical decisions hinge on this. The stakes just couldn't be clearer.
It's not about passing an exam.
No, this is about being a safe, functioning clinician. So before we jump into the molecules and the mechanisms, let's define the conceptual nucleus of this entire field.
The big picture nugget.
Yeah. What's the core idea driving all of clinical biochemistry?
I think the core idea, if you distill it all down, is simply balance.
Balance.
That's it. We are constantly observing the body's systems, the kidneys, the lungs, the hormones, the cellular enzymes, as they strive relentlessly to maintain a stable internal environment. Homeostasis.
And this isn't a passive process.
Not at all. It's a constant battle against massive external flux, whether that's dramatic shifts in your diet, intense exercise, or just the physiological stress of a serious illness.
So the body's compensatory mechanisms are always at work, trying to keep things like pH, osmolality, and essential energy pathways within these razor-thin tolerances.
Exactly. Sophisticated, interlinked, and constantly working.
Right. Whether it's maintaining the arterial pH between 7.35 and 7.43, or keeping the potassium concentration so tightly controlled to protect the heart's rhythm.
Or making sure the brain cells don't swell up dangerously because of osmotic shifts.
It's all about that fight for stability. And when those complex interlinked mechanisms finally fail or they're just overwhelmed,
that is precisely when we see the dramatic clinical syndromes that bring a patient to the hospital.
Okay, let's unpack this by starting where it all begins for the clinician, at the bedside and in the lab.
The diagnostic framework.
Right. And you mentioned a lot of these biochemical and metabolic disorders, they're clinically silent, or they just have these vague, non-specific symptoms like fatigue or nausea.
Which means they're almost always first detected by lab testing.
But here's the crucial caveat for you, the learner. When physical signs do manage to show up,
they are often extremely specific. They point like a laser beam directly to the underlying biochemical problem.
So that's the point we need to anchor right away. The physical exam is a search for those rare but incredibly specific clues.
Even if the primary pathology is happening at the molecular level. Let's look at a few examples. Let's start with hyperlipidemia, the excess of cholesterol or triglycerides.
Okay, so we're looking for visible lipid deposition.
Exactly. And there are two classic anchors here.
The first one is xanthelasma, which are those yellowish fat deposits you see, typically around the eyelids.
Right. And then there's the much more pathognomonic sign, the tendon xanthoma.
And that's when cholesterol actually gets deposited in the tendons themselves.
Yes. Typically the Achilles tendon or the extensor tendons of the hand, the extensor digitorum.
Yeah.
If you feel or see a thickened Achilles tendon xanthoma, especially in a younger or middle-aged patient,
your mind should immediately go to one thing.
Immediately anchor that thought to familial hypercholesterolemia, or FH. That sign strongly suggests a severe, long-standing elevation of LDL cholesterol. You cannot miss that clue.
And then we move to correlating signs with volume status.
Right.
So the primary indicators of hypervolemia or fluid overload would be a raised jugular venous pressure, the JVP, which you can see in the neck.
And of course, ankle edema, both of those signs indicate fluid expansion, usually in the extracellular compartment.
And on the flip side, for hypovolemia, the depletion of circulating blood volume, we're looking for those classic cardiovascular markers.
Low blood pressure, a rapid pulse or tachycardia, and peripheral signs like a dry mouth, and importantly, reduced skin turgor.
That skin turgor check, where you pinch the skin and it stays tented.
That tells you that the interstitial fluid volume is contracted. It's a really useful sign.
We also need to be aware of the neurological signs, because they can indicate direct cellular injury from these rapid osmotic shifts.
This is where the biochemistry directly hits the organ that's most sensitive to volume change, the brain.
So if a patient develops acute hyponatremia, a sudden low plasma sodium,
Water is going to rush into the cells to try and equalize that sudden drop in external osmolality,
and that causes rapid cell swelling, cerebral edema.
which clinically shows up dramatically. We're talking vomiting, confusion, somnolence, seizures, and potentially coma.
And the key factor here is the speed of the change.
The acute onset, yes. That's the key determinant of how severe the symptoms are, almost regardless of the absolute sodium number.
And finally, we should just mention those ultra-rare but classic findings, because recognizing them is key for diagnosing specific inherited disorders.
Right, these are the ones you see in textbooks, like the cherry red spot on the fundus, which you can see during an eye exam.
Which is a critical pointer towards conditions like gangliosidosis.
Or a photosensitive rash, which should immediately make you think about investigating a porphyria.
So the clinical lesson to lock down here is what?
Physical signs in metabolic disorders are often rare, but when they're present, they are extremely specific. They function as diagnostic anchors. They point you directly to the underlying chemistry and the organ system that's being affected.
Okay, so moving from the bedside to the lab, we rely on biochemical investigations for really 3 broad clinical reasons.
That's right, the 3 functions of ordering a test. First is screening asymptomatic people.
Like newborn screening for inherited metabolic disorders, like PKU, or running a standard lipid panel during a routine health check to assess someone's cardiovascular risk.
The second is diagnosis, helping us confirm or differentiate the cause of a patient's presenting symptoms.
And third is monitoring.
Right, monitoring the progression of a known disease or checking the patient's response to treatment like measuring TSH levels to see if their thyroid replacement therapy is working.
The technology that supports all this is just breathtakingly advanced now. We're talking about central laboratories with these high-throughput analyzers.
Heavy automation, deep IT integration, they can process thousands of specimens incredibly fast.
But we have to contrast that with the other critical operational strategy, which is point-of-care testing, or POCT.
And this contrast is vital. The central lab gives you the gold standard, high precision, robust quality control, and the lowest cost per test.
But POCT, which brings some of these analytical systems right to the bedside, gives you results almost instantaneously.
And that speed is the trade-off.
And that speed, as we know, can save a life. We should probably just briefly anchor the specific analytical modalities they use, because knowing how a molecule is measured adds some depth to your understanding.
Okay, so for rapid measurement of electrolytes like sodium, potassium, chloride, and blood gases, we primarily rely on ion-selective electrodes, or ISCs.
And they work by measuring the potential difference across a membrane that's specific to that ion.
Exactly. Now, when we look at hormones, vitamins, or specific large proteins, the standard method is usually ligand assays, most commonly immunoassays.
Which is where we use antibodies to bind and quantify the target molecule we're looking for.
But the heavy-duty power tool of the lab, especially for screening for complex organics, drugs, or rare inherited disorders, is mass spectroscopy, often coupled with chromatography.
And that technique is just unbelievably specific and sensitive.
Yeah, it's unparalleled. It separates and identifies molecules based on their mass-to-charge ratio, absolutely essential for detecting those rare IMDs.
Okay, so here's a checking question for you, listener. This is designed to anchor the clinical relevance of that POCT discussion.
If a patient is severely hyperkalemic, let's say their K plus is 7.5 millimole, and they're showing ECG changes that threaten cardiac arrest, would you prefer a POC2 or a central lab test to guide immediate management, and why?
So if you need a moment to think about those trade-offs, just pause and review the distinction we just made.
The clinical preference in that acute, life-threatening scenario is overwhelmingly for POCT.
No question.
In a true emergency like severe hyperkalemia, the instantaneous result from the bedside device completely outweighs the minor loss of precision you might get compared to the central lab.
Because that speed allows for immediate life-saving administration of IV calcium gluconate and other agents.
Exactly. If you're waiting on the central lab, you have to remember that time delay is the enemy of cardiac stability in this scenario.
Okay, let's move on. We are now entering the immense landscape of fluid and electrolyte balance. This is, you could argue, the most fundamental aspect of clinical biochemistry.
It governs everything: cell volume, circulating blood volume, the body's entire electrical stability.
So let's start by just setting the scene. The distribution of water.
The standard anchor is that total body water is about 60% of body weight in an adult male, so maybe 40 liters in a 70-kilogram man.
And this water is critically split into two main compartments, separated by the cell membrane.
Right. 2/3 of that water, about 25 liters, is the intracellular fluid, or ICF. And in there, potassium is the dominant cation.
The remaining 1/3, about 15 liters, is the extracellular fluid, or ECF, where sodium is the dominant plasma.
Yeah.
And that ECF is further split into the interstitial fluid and the plasma.
And that concentration gradient, high potassium inside the cells, high sodium outside, that's the engine of life. It's maintained by that universally present, energy-hungry sodium-potassium pump.
The no-K ATPase.
Exactly. And maintaining those gradients is essential for the excitability of all our conducting tissues, nerves, muscles, and of course, the heart.
Okay, now let's move to what you call the most critical conceptual anchor in this entire field.
The sodium-water paradox.
This distinction is what separates the assessment of volume status from the assessment of concentration status.
And it's so important to get this right. Let's use a powerful analogy.
Okay.
Think of sodium as the ECF volume controller.
Like a dam holding back the river.
Precisely. Why? Because water follows salt. Therefore, the total amount of sodium in the body determines the overall volume of the ECF.
So if you have too much total sodium, you have excess volume or hypervolemia.
And if you have a deficit of total sodium, you have volume contraction, hypovolemia.
Okay, so that's sodium. What about water?
Conversely, water movement, which is regulated by osmolality, is the cell volume controller. Think of it like a pressure gauge.
Right.
Changes in plasma osmolality, which is mostly driven by the ECF sodium concentration control the movement of water across cell membranes, and that dictates the volume of the ICF.
And that's what causes the concentration disturbances, like hypernatremia or hyponatremia.
Exactly. So the fundamental high-yield clinical lesson here is this: disturbances in total body sodium cause volume issues, hypo or hypervolemia.
And disturbances in free water relative to that sodium cause concentration or osmolality issues, or hyponatremia.
Never confuse the two. They guide entirely different management strategies.
This is where the kidneys step in as the master architects, right?
Absolutely. The body's capacity to handle massive swings in dietary sodium intake while maintaining a normal ECF volume and composition is just astonishing. And this fine control is executed segment by segment within the nephron.
So let's visualize the nephron as a series of specialized factories, each with its own unique machinery and its own transport goals.
A nephron roadmap.
Exactly. Let's map this roadmap, anchoring the function, the key machinery, and the crucial drug targets for each section.
Okay, factory 1. The proximal renal tubule, the PT, this is the bulk reabsorber, it handles roughly 65% of the filtered sodium load.
So its primary job is just mass processing.
Exactly. And crucially, it's highly permeable to water, so sodium reabsorption here is almost perfectly isotonic. Water just follows the salt, so the concentration of the fluid doesn't really change much.
And the key machinery here?
It includes the high-capacity NA, AT-PACE pump driving transport, the SGLT2 co-transporter, which is responsible for glucose reabsorption, and the NHE3 exchanger, which helps to reabsorb almost all of the bicarbonate.
So the clinical significance here is that drugs targeting this segment, like the SGLT2 inhibitors, they block glucose and sodium reabsorption,
which promotes a substantial salt and water loss. Great for lowering blood pressure and protecting the kidneys in diabetes. Also, acetazolamide, a carbonic anhydrase inhibitor, works here.
Okay, factory 2, the loop of Hemel. specifically the thick ascending limb.
This segment handles about 25% of the filtered sodium. Its goal is to set up the osmotic gradient. It's a specialized diluter because it is impermeable to water.
So sodium gets pumped out, but water can't follow.
Right, which dilutes the tubular fluid. The crucial piece of machinery here is the electroneutral NKCC2 cotransporter. It moves one sodium, one potassium, and two chloride ions into the cell.
And this is a major anchor point for pharmacology. NKCC2 is the target of the loop diuretics, like furosemide.
Yes, and by blocking NKCC2, you interrupt the reabsorption of a massive 25% of the sodium load, and you destroy the hypertonic osmotic gradient that the kidney needs to concentrate urine later on.
Which is why loop diuretics are the most potent diuresis tools we have. They just disrupt the entire system.
They really do. Okay, factory 3, the early distal tubule. Now we're into fine-tuning, handling about 7% of the sodium.
Still water impermeable, still continuing the dilution process.
Correct. The unique machinery here is the NCCT sodium chloride cotransporter, and this segment is also critical for calcium homeostasis as it reabsorbs calcium in exchange for sodium.
And the anchor drug here is the thiazide diuretic, which blocks that NCCT transporter.
They are less potent than the lukes, but their action is sustained, and they have that unique clinical benefit of promoting calcium retention, which is useful in patients with hypercalciuria.
Okay, last stop. Factory 4, the late distal tubule and cortical collecting ducts.
This is the final regulator. It handles only the last 2 to 3% of the load, but this is where all the hormonal decision-making happens. Sodium enters the principal cells through the epithelial sodium channel, or ENaC.
And this sodium reabsorption creates an electrical gradient.
A lumen-negative potential, which then drives the secretion of potassium and hydrogen ions.
And this final factory is highly regulated by two hormones. Vasopressin, or ADH, controls water permeability, and the steroid hormone, aldosterone.
Aldosterone stimulates ENaC activity, which enhances sodium reabsorption and potassium secretion.
Which brings us to our final drug anchor, the potassium-sparing diuretics.
Exactly. Amiloride directly blocks ENaC, while spironolactone acts as an aldosterone antagonist. Since sodium reabsorption and potassium secretion are linked here, inhibiting the sodium reabsorption reduces potassium secretion.
Making them unique because they don't cause hypokalemia.
Precisely.
Now, these factories aren't just running on autopilot. They are very tightly regulated. The entire system is obsessed with maintaining volume and pressure.
And the key mechanism is the renin-angiotensin-aldosterone system, or the RAA system. It's the ultimate volume sensor.
And it gets activated when renal perfusion pressure drops, or when the sympathetic nervous system is active,
or when the macula densa senses a low sodium chloride concentration in the distal tubular fluid, which tells it that the earlier parts of the nephron were over-reabsorbing.
And this stimulus triggers the release of renin,
which starts the cascade leading to the production of angiotensin II. And angiotensin II is powerful. It causes vasoconstriction to raise BP acutely. It directly stimulates proximal sodium reabsorption.
And most importantly, it triggers the release of aldosterone from the adrenal cortex.
Right. And aldosterone then acts on the collecting duct to amplify sodium and water retention. The overall effect is a powerful defense against hypovolemia. It raises blood pressure and expands the ECF volume.
But there's a counterbalance.
Yes, the natriuretic peptides ANP and BNP. These are released from the heart when the atria and ventricles are stretched by volume excess. They inhibit sodium reabsorption and vasodilate, effectively putting the brakes on the RAA system.
So, given these mechanisms, problems in sodium balance tend to present primarily as disruptions in the ECF volume.
Exactly. Either hypovolemia, which is volume contraction, or hypervolemia, volume expansion.
So let's start with hypovolemia. This is a reduction in circulating volume caused by fluid losses that contain sodium.
Things like GI loss, heavy sweating, diuretic use, or internal sequestration like in a bowel obstruction.
And the clinical presentation is what you'd expect: thirst, postural dizziness, weakness.
But the diagnostic workup contains a really critical anchor for you as a learner. In hypovolemia, the serum sodium concentration is often normal.
Because both salt and water were lost proportionally.
Right. However, the serum urea is almost always elevated, while the creatinine may remain normal.
Okay, so why is that distinction? High urea, normal creatinine, so critical?
Because the kidney is desperately trying to conserve volume. It's using the RAA system and ADH release, and this effort significantly reduces the urine flow rate.
And urea, unlike creatinine, is highly reabsorbed by the tubules when the flow is slow.
Exactly. So the high urea reflects a lack of flow and excessive reabsorption, not necessarily poor glomerular filtration. Creatinine, which reflects the GFR, only rises if the volume loss is severe enough to cause acute kidney injury. We call this a pre-renal picture.
And because the kidney is retaining everything, the urine sodium concentration will be appropriately low, right?
Very low, typically less than 30 millimole.
And for management, the anchor must be about effective replacement. We have to choose the fluid that best expands the ECF volume.
So while giving pure water, like 5% dextrose, sounds hydrating, it distributes across the entire 40 liters of total body water. Only a tiny fraction ends up in the plasma volume.
So crystalloids, specifically isotonic fluids like normal saline, are the fluid of choice for resuscitation. They primarily expand the ECF where the deficit actually is.
Let's just do a quick check-in on that specific diagnostic point. Listener, if a patient is severely hypovolemic, why is their urea level likely high, even if their kidney function, their creatinine, is near normal? Just think about the kidney's response to volume loss.
The answer we want you to lock down is this. The low circulating volume triggers RAA and ADH release, leading to massive salt and water retention and a significantly reduced urine flow rate.
And that lack of flow allows for greatly increased tubular reabsorption of urea, leading to a high serum urea level. Creatinine remains normal because the glomerulus is still filtering okay, but the tubules are conserving everything.
If that concept wasn't crystal clear, just rewind and re-listen to that diagnostic nugget on urea and creatinine.
Okay, let's switch to hypervolemia, sodium, and water excess. This is almost never seen in healthy individuals. It signals a major systemic disorder.
Most commonly cardiac failure, cirrhosis nephrotic syndrome, or late-stage kidney failure.
And the core pathophysiology, especially in heart failure and cirrhosis, is secondary hyperaldosteronism. This happens when the underlying disease reduces the effective arterial filling, the amount of blood actually circulating and being sensed by the volume receptors.
So in heart failure, cardiac output is low. In cirrhosis, blood pools in the splanchnic circulation or albumin production drops.
And both of those scenarios trick the RAA system into thinking the body is hypovolemic.
Which leads to continuous RAA activation, excessive salt and water retention, and the resulting peripheral edema.
We should note the important exception. Primary hyperaldosteronism, or Conn's syndrome, causes sodium retention and hypertension, but because the volume excess is detected quickly and triggers natriuretic peptides, these patients rarely develop generalized edema.
And management here focuses on treating the underlying cause, restricting dietary sodium very aggressively, restricting fluid, and using diuretics.
And given the sustained retention and volume excess, you need potent drugs that block bulk reabsorption, like the loop diuretics, to really move that massive fluid load.
So the key takeaway for this whole section is that the kidney segments, the PT, loop, DT, CD, they're highly specialized factories with distinct transport proteins.
And diuretics exploit these specific proteins to exert calculated control over ECF volume. Knowing the site of action dictates the drug's potency and its side effects.
Okay, we've established how the body controls volume using total sodium. Now let's shift to how the body controls concentration, or osmolality, using water.
The kidney has to be able to produce urine that is far more concentrated or far more dilute than plasma. And this is achieved via the amazing countercurrent mechanism,
which involves the loop of Henle and the collecting duct system. This can be complex, so let's use that anchor metaphor you mentioned.
The osmotic ramp and the gatekeeper.
Okay, so the loop of Henle's active transport of sodium via NKCC2 and its water impermeability creates the osmotic ramp.
Right, a steep gradient of saltiness and osmolality that increases dramatically from the cortex down to the deep inner medulla. This gradient is the potential to reabsorb water.
And the gatekeeper is the hormone vasopressin, or ADH.
ADH decides if water can climb that ramp. When ADH levels rise, it inserts AQP2 channels, or aquaporins, into the membranes of the collecting ducts, making them permeable to water.
Water then flows passively out of the tubule and gets reabsorbed by osmosis back into that hypertonic medulla,
resulting in highly concentrated urine.
So if you are dehydrated, ADH rises, the gates open, and water climbs the ramp.
And if you have water overload, ADH is suppressed, the collecting ducts become impermeable, and the fluid remains dilute and is just excreted as maximally dilute urine.
Okay, let's talk about the problems. Hyponatremia, a sodium less than 135.
This is the most common electrolyte disturbance in hospitalized patients, and it always signifies a relative excess of water compared to sodium. The danger is to the brain cells, which rapidly swell as water flows inward.
And we anchor the diagnosis by categorizing the patient based on their ECF volume status: hypovolemic, hypervolemic, or euvolemic.
And the key diagnostic nugget for that euvolemic category is SIADH, the syndrome of inappropriate ADH release. In SIADH, ADH is secreted regardless of the normal physiological stimuli.
So you get pure water retention.
Right, and the diagnosis requires the patient to be clinically euvolemic and have low plasma sodium and osmolality. Critically, because ADH is present, the urine is not minimally dilute and the urine sodium is inappropriately high.
But the single most critical concept in managing any hyponatremia is understanding brain adaptation and the rate of correction.
This is so important. If the hyponatremia is acute, meaning the onset is known to be less than 48 hours,
the brain hasn't had time to adapt, and the risk of rapid cell swelling and cerebral edema is paramount.
which demands rapid correction, typically using hypertonic 3% saline to quickly raise the plasma sodium and protect the brain.
However, if the hyponatremia is chronic, which is the majority of cases,
The brain cells have had time to adapt. They've jettisoned cellular osmolytes, potassium, and organic compounds to normalize their volume despite the low external osmolality.
so if we correct this chronic state too quickly,
The sudden rise in ECF osmolality pulls water out of those adapted shrunken neurons,
which causes profound neuronal shrinkage and can lead to the devastating complication known as osmotic demyelination syndrome, or ODS.
which can cause locked-in syndrome or death. This is why there is a rigid correction rate limit. You must not exceed a 10 to 12 millimoles rise in 24 hours. Slower is often safer.
So the lesson here is osmolality shifts cause cell volume changes, most dangerously in the brain.
And the speed of the onset, acute versus chronic, is the single most important factor determining both symptom severity and the maximum safe rate of correction.
Rapid correction of chronic hyponatremia is malpractice.
Absolutely. Now, for hypernatremia or high plasma sodium, this is due to a deficit of water relative to sodium.
Typically from inadequate water intake or a failure of the vasopressin system, which we call diabetes insipidus, or DI.
And this can be central DI from insufficient ADH production or nephrogenic DI where the kidneys can't respond to ADH. In either case, the kidney can't concentrate urine.
Clinically, hypernatremia leads to neuronal dehydration and brain shrinkage, causing thirst, delirium, lethargy, and coma.
Management involves slow and careful correction, using fluids like 5% dextrose or hypotonic saline to replace the calculated free water deficit. Again, avoiding rapid overcorrection is key.
Okay, let's shift to the body's electrical conductor, potassium.
K plus ite. This is the major intracellular cation, essential for setting the resting membrane potential and for generating action potentials in all excitable tissues, nerve, muscle, and crucially the heart.
So we had to anchor potassium as the body's electrical stability control.
Yes. And while most filtered K plus is reabsorbed, the precise control comes down to the final adjustable step. K plus secretion in the late distal tubule and collecting ducts via the ROM-K channel.
And the regulation is exquisitely sensitive.
Hyperkalemia immediately stimulates aldosterone release, which then enhances K plus secretion by the kidney. It's a perfect negative feedback loop.
And we also have to understand the critical shifts between the ECF and ICF.
Right. Acidosis drives K plus out of cells, leading to hyperkalemia. Conversely, alkalosis, insulin, and catecholamines drive K plus into cells, leading to hypokalemia.
Which is why insulin therapy in DKA requires such careful potassium monitoring.
Exactly, because it shifts K plus rapidly back inside the cells.
So let's talk about hypokalemia, K plus less than 3.5. This is usually due to abnormal loss, either GI or renal.
And for you, the learner, differentiating renal wasting syndromes is very high-heeled. We can anchor this by assessing blood pressure and urinary calcium excretion.
So if the patient have high BP and metabolic alkalosis, we suspect mineralocorticoid excess, like Conn syndrome or Little syndrome.
Right, but if the patient has a normal or low BP with metabolic alkalosis, you have to look for inherited tubulopathies that mimic chronic diuretic use.
Bartter syndrome mimics a loop diuretic and is characterized by increased urinary calcium.
And Gittleman syndrome mimics a thiazide and is characterized by the high-yield finding of decreased urinary calcium. The clinical signs help you target the missing factory part.
Clinically, hypokalemia causes muscle weakness, constipation, and life-threatening arrhythmias. The ECG changes are definitive.
The appearance of U waves, T wave flattening, and ST depression.
And what about hyperkalemia, K plus greater than 5.0.
Extremely common, primarily due to reduced excretion from kidney injury or drug effects like ACE inhibitors or spironolactone. It's often asymptomatic, but the cardiac risk demands immediate attention.
So the vital sign here is the ECG.
You treat the ECG, not just the number. The earliest and most critical sign is the development of tall, symmetrical, peaked T waves.
And as it progresses, you see loss of the P wave and dangerous QRS widening, which is a precursor to VFib and cardiac arrest.
The management of severe hyperkalemia, say K plus over 6.5 or with any ECG changes, follows a strict, urgent, three-step sequence. You have to commit this to memory.
Disappointing.
Stabilize the cardiac membrane. Give IV calcium gluconate immediately. This does not lower the potassium level, but it antagonizes its cardiac effects, buying you time.
Step 2.
Shift K plus into cells. Give IV insulin glucose. Sodium bicarbonate can also be used if the patient is severely acidotic.
And finally, step 3.
Remove K plus from the body. Use diuretics, newer cation exchange resins, or, if necessary, dialysis.
Okay, another quick check-in question. A patient is severely hypokalemic and has a metabolic alkalosis due to chronic self-induced vomiting. If you measure their urine, what is the expected urine chloride concentration and why? Think about where that chloride is being lost.
The critical anchor here is chloride loss. Vomiting removes hydrochloric acid, which is rich in chloride.
So this loss, coupled with the volume depletion, stimulates the kidney to aggressively retain sodium and chloride to protect volume.
Meaning the urine chloride concentration will be low, typically less than 30 millimolo. This helps differentiate this kind of alkalosis from something like mineralocorticoid excess.
So the clinical lesson for potassium is that imbalances are immediately dangerous due to cardiac risk.
And you must always prioritize membrane stabilization with calcium, followed by shifting, and finally removal. The ECG is your most important tool.
Okay, moving to the final element of balance, acid-base homeostasis. Plasma pH has to be tightly regulated between 7.35 and 7.43.
And the primary defense is the bicarbonate buffer system, which is managed by two distinct organs. The concentration of CO2 is managed by the lungs or the respiratory system.
And the concentration of bicarbonate, or HCO3, is managed by the kidneys, the metabolic system.
And the kidney's role is essential. It has two main tasks. First, the proximal tubule reabsorbs 85% of filtered bicarbonate. Second, the distal nephron secretes H+ ions into the urine.
And when we approach acid-base problems, we have to diagnose the primary disturbance and then assess the secondary compensation.
Remembering the speed dynamic, respiratory compensation changing PCO2 is fast, almost immediate. Renal or metabolic compensation changing HCO3 is slow. It takes days.
So let's focus intently on metabolic acidosis, a primary fall in plasma HCO3 concentration.
This is categorized by the anion gap, or AG. This calculation is absolutely crucial for diagnosis.
So you can have a normal anion gap acidosis, also called a hyperchloremic acidosis.
This happens when bicarbonate is lost and chloride is increased to maintain electroneutrality. The primary anchor cause is diarrhea from GI bicarb loss. It also includes renal tubular acidosis, or RTA.
And then there's the increased anion gap acidosis.
This is the dangerous category. It happens when large quantities of unmeasured toxic anions accumulate, consuming bicarbonate.
And the classic mnemonic anchors are ketoacidosis, lactic acidosis, or exogenous toxins like methanol or ethylene glycol.
You always have to calculate that gap.
Okay, what about metabolic alkalosis? A primary rise in HCO3.
This is usually caused by either loss of acid or volume depletion. The most classic cause is sustained, self-induced vomiting, losing acid-rich gastric contents.
And the resulting hypovolemia triggers the RAA system, which drives H+ secretion and bicarbonate retention by the kidney.
And this type of alkalosis is saline responsive. You cannot correct it until you replace the volume, usually with normal saline.
Last check-in for this section. If a patient presents severely acidotic low pH, low HCO3, but their PCO2 is also low, what is the likely primary disturbance, and how do you know?
The observation of a low pH and low HCO3 with a low PCO2
indicates that the primary disturbance is the metabolic acidosis, and the low PCO2 is the appropriate respiratory compensation.
Exactly. The patient is hyperventilating to blow off CO2 and acid to try and raise the pH back towards normal.
So the lesson here, calculate the anion gap in every metabolic acidosis. It immediately separates GI and renal losses from life-threatening toxic accumulation.
And remember, the speed of compensation tells you which organ system is driving the primary pathology.
All right, let's dive out of the aqueous environment of electrolytes and into the oily world of lipids. cholesterol and triglycerides.
Critically important. High LDL cholesterol is the major treatable risk factor for global cardiovascular disease, and severely elevated triglycerides cause acute pancreatitis.
And since lipids are purely water-soluble, they have to be transported throughout the body inside these spherical packages called lipoproteins.
Right. And we have to understand the two major pathways for lipid transport. First, the exogenous or dietary pathway.
So when you eat fat, the gut absorbs it and packages it with a specific protein, ApoB48, into these huge particles called chylomicrons.
They enter the circulation via the lymph. Then, in the capillaries, the triglycerides inside are rapidly hydrolyzed by the enzyme lipoprotein lipase, or LPL, releasing fatty acids for the tissues to use. The remnants are then cleared by the liver.
Okay, that's exogenous. What about the endogenous pathway?
This originates in the liver. The liver packages its synthesized lipids into very low-density lipoproteins, or VLDLs, which contain the full-length protein, ApoB100.
And VLDLs undergo a similar process, transforming into IDLs and finally into LDL, which is the primary plasma carrier of cholesterol.
And then the third crucial process is reverse cholesterol transport, which is mediated by HDL, or good cholesterol.
HDL's job is to collect excess cholesterol from peripheral tissues and bring it back to the liver for excretion. It's the body's cleanup crew.
Now, cellular cholesterol metabolism is a finely tuned feedback loop, and we need to anchor three crucial molecular players in the liver that control LDL cholesterol levels, because these are the precise targets for modern therapy.
Number 1.
HMG-CoA reductase, the rate-limiting enzyme responsible for the synthesis of cholesterol inside the cell.
Number 2.
The LDLR, or LDL receptor, the critical surface receptor that clears LDL cholesterol from the circulation.
And number 3.
PCSK9, an enzyme that specifically targets the LDLR for destruction.
Yeah, this is where the mechanism gets really fascinating and where the new drugs come in. So when a patient takes a statin, an HMG-CoA reductase inhibitor,
The cell senses low intracellular cholesterol. This triggers a regulatory protein called SREBP to increase the production of LDLRs to compensate and pull more cholesterol from the blood. That's the beneficial effect.
but the body has this weird counter-regulatory mechanism. It's almost like self-sabotage.
It is. SRBP, when it's activated, not only increases LDLR production, but it also increases the production of PCSK9.
And this PCSK9 enzyme then binds to the newly made LDLRs and drags them into the cell's lysosomes for degradation.
It destroys the very receptors the cell just made, and this process blunts the maximum effectiveness of the statin.
So wait, the cell, in trying to grab more cholesterol with the LDLR, simultaneously creates the enzyme that destroys that very receptor. That sounds inherently inefficient.
It does, but it's a critical regulatory balance. And that balance is why the newest class of drugs, the PCSK9 inhibitors, are so revolutionary.
These drugs neutralize or degrade the PCSK9 enzyme itself.
And by removing that self-sabotage mechanism, they allow LDLRs to accumulate massively on the cell surface, leading to a profound, often 60 to 70% reduction in circulating LDL cholesterol.
Even in patients who are already on high-dose statins.
And the reason for their exceptional potency is that they don't lower intracellular cholesterol directly, meaning they don't trigger that SREBP feedback loop that produces more PCSK9 in the first place.
So they bypass the cell's compensatory system. That's the high-yield concept.
Exactly.
So let's talk about the presenting problems. The most common is polygenic hypercholesterolemia, but the learner has to be trained to recognize the severe monogenic forms.
Like familial hypercholesterolemia, or FH. It's the most common severe genetic disorder, often autosomal dominant, caused by variants in the LDLR gene.
These patients have LDL-C levels double the normal range from birth and face a 20 to 40-year acceleration of premature cardiovascular disease risk.
And as we anchored earlier, the physical signs are crucial. Tendon xanthomas and corneal arcus before age 40.
And since FH carries such a profound risk, its diagnosis requires genetic and biochemical screening of all first-degree family members.
It's a highly cost-effective public health approach for case detection.
Then we have hypertriglyceridemia. Common secondary causes are uncontrolled type 2 diabetes, excess alcohol, and central obesity.
And while moderate elevations contribute to CVD, the major acute clinical risk we have to anchor is that severe hypertriglyceridemia levels over 10 millimole carries a high risk of acute pancreatitis.
Which is a medical emergency, totally distinct from the chronic risk of atherosclerosis.
And a quick investigation note, when triglycerides are high, the common formula to calculate LDL-C becomes inaccurate.
In these cases, it's much more accurate to use non-HDL cholesterol or measure ApoB100.
Because these metrics capture all the atherogenic particles, including the VLDL and IDL remnants and the small, dense LDL.
So management is always aggressive and layered. It starts with intensive non-pharmacological measures, right?
Diet, weight loss, exercise, even small changes yield significant benefits.
And pharmacologically, the strategy is hierarchical, with LDL as the primary target.
First line is statins. They're the foundation, reducing LDL-C by up to 60%. But you have to note the nuance. Statin use is associated with a small but measurable increase in the risk of new-onset type 2 diabetes.
We accept this risk because the cardiovascular benefit in preventing heart attacks and strokes vastly outweighs it in high-risk patients.
Exactly. Then you have add-ons like ezetimibe or the extremely potent PCSK9 inhibitors. And for high triglycerides, you'd use fibrates or N3 fatty acids to get the level below that 10 millimole pancreatitis threshold.
Okay, let's do a quick check-in on that investigation nugget. Why might non-HDL cholesterol be a more accurate assessment of overall cardiovascular risk than calculated LDL-C in a patient with high triglycerides?
Well, chemically, the LDL-C calculation is unreliable when TGs are high. And pathophysiologically, high TGs are associated with lots of other atherogenic particles.
Small, dense LDL, VLDL, and IDL remnants.
Right. And since non-HDL cholesterol includes all the ApoB-containing lipoproteins, it provides a better single consolidated measure of the total circulating atherogenic risk.
The lesson here, LDL is the primary target. Statins are the foundation. And the immense potency of new agents targeting PCSK9 highlights the critical role of the LDLR and cell-level compensatory mechanisms.
Okay, finally, let's turn to the most diverse and often devastating area, the inherited metabolic disorders, or IMDs.
A large group of rare single-gene defects. They're rare, but recognizing them is essential because many are highly treatable, and missing them can be catastrophic.
And we can use a simple two-point framework to anchor the pathophysiology. A single gene defect causes enzyme loss, which leads to two core outcomes.
1. Accumulation of toxic metabolites upstream of the enzyme block.
And 2. Inability to synthesize essential products downstream.
So let's talk about some examples. The classic one is phenylketonuria, or PKU.
A defective phenylalanine hydroxylase enzyme. Phenylalanine accumulates and is directly neurotoxic, leading to profound, irreversible disability if untreated.
The clinical anchor here is the power of early intervention. Lifelong dietary restriction is essential for normal cognitive development.
And we have to remember the separate critical risk of maternal PKU syndrome. If a woman with PKU becomes pregnant and doesn't follow her diet, the high maternal phenylalanine levels are teratogenic to the fetus.
Another important one is homocystinuria.
Defective cystathione beta synthase, leading to homocysteine accumulation. This is a multi-system pathology. Developmental delay, displaced eye lenses, and most dangerously severe recurrent arterial and venous clots.
Then there are the life-threatening urea cycle disorders.
OTC deficiency is the most common. It prevents ammonia from being disposed of, leading to acute, life-threatening hyperammonemia and encephalopathy. Management is urgent and requires long-term protein restriction and urea scavenging medication.
Moving to carbohydrates, galactosemia.
A defective GALT enzyme. Inability to metabolize galactose. In a neonate, this leads to a devastating crisis with liver and kidney failure, sepsis, and cataracts. Treatment is a galactose-free diet, but neuropsychological impairment often persists.
Then there are the glycogen storage diseases, or GSDs.
Defects in glycogen formation or breakdown. The phenotype depends on the enzyme. For example, GSD type I, or von Gierke disease, causes severe fasting-induced hypoglycemia and lactic acidosis. Management is all about avoiding fasting.
We also have to consider disorders of mitochondrial energy metabolism.
These typically involve defects in fatty acid oxidation, like MSAD deficiency. This presents as hypoketotic hypoglycemia and encephalopathy, as the body can't switch from glucose to fat for fuel correctly. It can be triggered by fasting, alcohol, or intense exercise.
And finally, the lysosomal storage disorders, or LSDs.
The lysosome is the cell's recycling center. If a degradative enzyme is missing, macromolecules accumulate, causing progressive tissue damage.
A key example is Fabry disease.
An X-linked alpha-galactosidase deficiency. Features include burning pain, skin lesions, kidney disease, and stroke.
And this highlights the limitations of modern therapy.
Exactly. Enzyme replacement therapy is available, but being a large protein, it does not effectively penetrate the blood-brain barrier, so neurological symptoms may continue to progress despite treatment.
Okay, last category.
The porphyrias.
Enzymatic defects in the heme biosynthesis pathway. We'll focus on the acute porphyrias, the neurovisceral forms.
Like acute intermittent porphyria or AIP. These are characterized by acute attacks of excruciating abdominal pain, psychiatric symptoms, neuropathies, and tachycardia. AIP is caused by defective PBGD, leading to the accumulation of toxic precursors, ALA and PBG.
And the attacks are triggered by things that stress the liver's heme production, fasting, alcohol, certain drugs.
Management is all about avoiding triggers and terminating acute attacks quickly with high doses of carbohydrates or 5-E dextrose. For severe cases, IV heme arginate is used, which acts as a powerful feedback inhibitor.
So the lesson for all IMDs is that they are multi-system diseases.
And diagnosis relies on knowing the site of the enzyme block, identifying the toxic upstream metabolite, and understanding that the timing of intervention often dictates the prognosis.
We have completed a demanding and exhaustive deep dive covering the interconnected systems of fluid, electrolytes, lipids, and complex metabolism, the hidden language that dictates the body's health.
We really navigated the nephron, identified the critical transporters and drug targets, analyzed the cardiac dangers of potassium shifts, and mapped the complex transport system of lipoproteins.
Including that molecular mechanism of the PCSK9 inhibitors.
Right. So reviewing our core anchors one last time, always remember the kidney's functional segments acting like specialized factories. Remember that total body sodium controls volume, while water movement controls concentration.
And never forget that the ECG is the non-invasive vital sign that dictates urgent management in potassium disturbances.
And finally, keep in mind the immense potency of modern drugs, like the PCSK9 inhibitors, which succeed precisely because they bypass the body's natural and sometimes self-sabotaging compensatory feedback loops. Keep digging into the why behind every single lab value.
To leave you with one final provocative thought that connects these disparate sections, we anchored 2 severe lipid disorders. Severe hypertriglyceridemia leads to acute pancreatitis, a sudden explosive inflammatory destruction of a single organ.
While familial hypercholesterolemia leads to accelerated, global, progressive cardiovascular disease affecting the entire arterial tree.
These are both single-gene defects in lipid metabolism, leading to radically different catastrophic outcomes. One sudden and localized, the other chronic and global.
So how does a single broken step in a shared biochemical pathway result in such organ-specific disasters?
It illustrates how deeply integrated these biochemical pathways truly are, and how pathology is often defined not just by the missing enzyme, but by the organ where the toxic accumulated molecule wreaks the most havoc.
So keep asking yourself, where does this accumulated molecule deposit, and what unique damage does that organ suffer? Thank you for joining us for the deep dive.
Until next time, stay well informed.